patient number 3, postmenopausal with N positive. Now, I have the impression that we did quite a good job in node-negative breast cancer patients. And then, obviously, the patients who have maybe 1 or 2 involved lymph nodes are coming to us and telling, well, yeah, but my neighbor in my room had a multigen assay, she's doing fine. And you told her that she has a multigen assay which is negative or low risk, and she's not receiving chemotherapy. Now, most people are telling me, oh, I have to do chemotherapy because I'm node positive. So what about also including the node positive breast cancer patients? Obviously not those with more than 4 lymph nodes, but those who have 1 or 2, or maybe at maximum 3 lymph nodes involved. So 50-year-old postmenopausal woman, again, she's a number fan because she's an IT specialist. She has the following clinical features. Detected in February 2021 with right side lobular breast cancer, breast conserving surgery with sentinel. She had a multifocal tumor, PT2, 2 out of 8 lymph nodes involved. She's hormone receptor positive, HER2 negative, Ki67 is 10%. So the little therapy was breast surgery, adjuvant radiation, chest wall and regional nodes with 50 grays. And well, again, node positive, quite a larger tumor. So the question is chemotherapy followed by endocrine therapy. Can we do endocrine therapy alone? Is it good enough? You are not sure, or you also need a gene expression profile to make your therapeutic decision. Please vote now. Okay, so majority still need a gene expression signature, almost 80%. So let's go for the gene expression signature. And here it is. So again, 50-year-old patient, IT specialist, multifocal tumor, PT2, 2 out of 8 lymph nodes involved, hormone receptor positive, HER2 negative, Ki67, 10%. She had an EndoPredict result with 3.2, which by definition is low risk. The likelihood of distant recurrence within 10 years, 9%. The absolute chemotherapy benefit at 10 years, 3%. The likelihood of late distant recurrence within years 5 to 15, 7%. So again, I think with this in hand, especially for this patient who is a fan of numbers, she's an IT specialist, she dealt quite good because she knows what the numbers are talking about. Because patients do not like a relative risk reduction or relative risks, they want to know the absolute one. So these are the numbers. Again, by definition from the lymph nodes, she would have received chemo. With these numbers here, maybe you can decide. And the next one is the next polling, and which is having this information in hand. Is it chemo followed by endocrine? Is it endocrine alone? Please vote now. Such a pity, not such a pity, but in the times when we did not have this kind of multigene assay, most of us, or many of us, would have opted for chemotherapy. So we can say in this patient, we skipped chemotherapy, and the patient was quite happy, and therefore we have one more, and one more we need is this one here. So the patient went for aromatase inhibitor. At this time, she has no evidence of disease, and most probably or possibly she will decide to have a somewhat longer treatment of endocrine therapy than just quote by quote 5 years. Let us see what the data are in postmenopausal women node positive. And these data are coming again from Dr. Philippis in the Journal of National Cancer Institute published. ABCSG 6 and 8, about 1/3 low risk. These patients are doing excellent at the 10-year follow-up with less than 5% distant metastasis, and 24% of them who had EP-clean high risk had metastasis, and very similar numbers from the TransAttack study showing us that these patients, again, about 20% being low risk with 5% long-term risk of late recurrences or late metastasis, and 40% of metastasis in the EP-clean high risk. Excellent, excellent tool in our hands to really tell our patients what their individual risk is and what we might do